So now the perimetry has come to you, the printout, and you have to decipher it, or you have to take decision that how do we correlate this with the present patient which is in front of you. Now, before that, you have to find out that there is nothing wrong in this. Whatever has been presented to me is the right one. And these things look very simple, but these are really very, very important. And many times in busy practice, we just ignore all these things. That some wrong patients, because you have to check the name, the wrong eye, and date of birth. Because date of birth, if it is given, the entire normative database changed, and so your comparative data becomes faulty. The comparison between unrelated program, because these are many programs, so always you have to compare if you are repeating perimetry with the same parameter, the same program. The unrelated parameters also should always remain same if you want to really compare over a period of time. Wrong correction of refraction and centration, vertex distance, all this will give you wrong perimetric finding, outcome. The incorrect and inadequate patient position and directions, because you are not doing it, but when patient is sitting on that machine, then may not be in the correct position. The eye is sometimes tilted, head is moved a little backward or forward. So all this will affect the outcome and the perimetric, whatever the patient's response is. So you have to be intelligent enough to identify that these things are not there. Then the prominent eyebrows will also affect the perimetry, droopy eyelids, because sometimes you see the upper part is showing defect, you feel that, oh, this is glaucomatous defect, but actually it is not because of that, it's droopy eyelids. The Gansfield phenomena, patients, I don't know how many of you have sat on yourself on the machine, automated perimetry, and done your test. Then you will realize the difficulty with the patient. Patients don't like this test, although we always insist. And whenever we have to say repeat the test, then patient always says, doctor, can't you do it without this test? So this, unless you do it yourself, you will not realize the difficulties, and then probably you can pick up these faults. So Gansfield phenomena, when one eye is covered, then always there is the retinal rivalry. So sometimes the eye which is covered, if that supersedes at that particular moment, then the patients will see everything as white. So those factor also affects the perimetry. The edge and rim defects, some of the examples I will show you. Clover leaf pattern, white scotoma, bizarre defect, means any defect which is not really correlating with your knowledge, anatomical knowledge or physiological knowledge, and which is some defect you are getting with the conditions of the patient, then you have to just think again that whether it's right or wrong, and not correlating clinically, because always you have to correlate. Now this field is something which looks like, as everyone say, it's inferior arcuate with the nasal step, but actually it is not, because the nasal step and the arcuate scotoma should always go towards the blind spot, because it starts from the optic nerve, which is, in this case, it is not. So that's why this is not the arcuate defect, but this is some rim defect or artifact. Now this one, if you see, means definitely it is going towards the blind spot, but this type of defect, because where all this, if you see the figures over here, 0, 0, 0 like this, in this arcuate fashion, means there is no condition which will produce like this. So this again is artifact. Maybe the patient has little moved backwards, so the rim has come over there, the inferior rim, and that is producing this defect. This again, it's a rim defect, again a rim defect. Now this is what we were talking about, in the patients, in the 4 quadrant. First, the 4 quadrants are checked when the test starts. And then, that time patient is very attentive. After that, patient goes to sleep. So all other spots show no sensitivity. So this is known as clover leaf pattern. And the moment you see this, it means the response is not correct, rather than interpreting that this is the advanced field defect. Now this, I was talking about the white scotoma, because just gently look at this. The moment you look, you see this is a white areas in the periphery, which no normal person can have that kind of sensitivity. If you read the numbers over here, it is around 45, 49, 50. which no human being, even in the central area, macular area, foveal area, will have that kind of sensitivity more than 39 or 40 decibel. So if that thing is there, you can rest assured this test is not proper. And this patient, when again test was repeated immediately after that, and with the correct explanation to the patient, this was the response, where everything is normal. Now always, whenever you see this, always see both the fields together also for the semianopic defect, because if you look at this, don't just interpret that the patient which is sitting in front of you is always glaucomatous, maybe having some different disease. And we always discuss about early Anderson's criteria for early glaucomatous defect. So I'll not go in detail, but hemianopic defect, early defect, we should not miss out. Sometimes we may erroneously treat patients with neurological patients. We treat with anti-glaucoma medication, and the patient is losing sight in due course. Now, what does this show? If everything looks the perimetry as normal, then before declaring it as absolutely normal field, always try to find out the vertical meridian, the decibel value. This is the only time when I recommend that you should read the decibel value. So if just on the vertical meridian pair points, just next to the vertical meridian, try to compare the decibel value. If the decibel value of more than three or more consecutive points are showing unidirectional depression, then move to the next column after that. And if next column also shows in the same direction, depression, then probably, although the field is not looking abnormal, but may be dealing with early hemianopic defect. So just I will read it for you. Each threshold value on one side should be compared with the corresponding value on the other side of the vertical meridian. Adjacent row first. At least 3 adjacent pairs along the midline should show a unidirectional difference in sensitivity. Then move to the next column of values, and at least 2 decibel difference is significant. So always try to look for this. Now there are certain pointers. If the defect has to be definitive, if it is not definitive, you have to repeat. In case of doubt, to repeat. First time a patient comes to me suspecting glaucoma, if the response is reliable, but if it is showing some defect, I never take it as an actual defect. Then after some time we repeat. Next time, unless say the 2 consecutive tests are showing similar defect, then only you should take it as a normal, as a real defect. Otherwise, it's always some problem. Now, both fields also put together, as I told you, to know the hemianopic defects, and look for red flags for fallacy, which I showed you just now. Now, these tests now, these days, not done much, blue and yellow perimetry, but about 10 years back, it was very popular for early glaucoma, or to detect pre-perimetric glaucoma. But here, why I put up this slide, because if you look at the gray scale, it's really defective. But it is not, because the sensitivity of blue and yellow perimetry, the decibel value will be less. So it is not abnormal, but the other analysis, step-back analysis, shows there is no abnormality. And this again, a neurological defect, quadrantic defect. So these defects, you should always keep your antenna open that I am not dealing only with glaucoma, maybe something different. Always correlate field with the clinical findings. Just now, this point was put up by Harsh also, that these 2 field, one is this, other one is this. One is glaucoma, other one is branch vein occlusion. So that you have to be careful. And learning curve, never rely on the first field. If it is reliable, even if it is reliable, but if it is showing normal, then yes, you can rely. But if it is abnormal, don't rely on this unless you can repeat the test. Now this is the first test. I have just marked the timing and the date, but false negative error was high. Now the same test, just after proper explanation, repeated after 5 minutes, and this is the field. So you can see the difference. Otherwise, sometimes I have seen, because doctors have started just on one field treatment, that considering sometimes advanced glaucoma, and patient is not having, because this patient also repeated after proper explanation, this was the field. Now this one is not really correlating clinically that this kind of defect, what defect will be this? But still, sometimes suppose in that pattern, if photocoagulation has been done properly, you may see that. But again, after proper explanation, this was the field. Same day, after some time. So I don't know, I don't have explanation that why this type of defect patient first time responded like that. And when you're following it up, like the first test was normal, which I showed you. The second test suddenly shows quite, because if you see, I'm showing this comparison because immediately it will point out that it's deteriorated. But don't take it, the second test or next test that it's deteriorated, unless you just again do the test and confirm it. So always confirm these tests by repeat testing before you take it for any abnormality or any deterioration. Thank you very much for your patient listening.
Thank you very much, sir, for your excellent talk as usual. How many of you have done the perimetry on yourself? Please raise your hands. So only a few. How many of you have done OCT on your eyes? So quite a few. The simple reason is that it is the objective test, so it's easy to get the result, but it creates more problem. The red disease is very common. If you see the superpixel coded images, color coded images, then many a time you find the red color either in 1 o'clock hour or in one quadrant, and the patient is diagnosed having a glaucoma. So Dr. Pandav is here, who is expert in OCT.